Good evening, everyone, and good afternoon for those of you in Western Canada. My name is Jim Doukets, and it's my pleasure to welcome you to this webinar on blood clots and COVID-19, answers for patients and families. I'm joined this evening by Dr. Tseng, hematologist in Toronto, Dr. Stephanie Young, a pharmacist from St. John's, Newfoundland, and I practice medicine in Hamilton, Ontario. Before we start, I wish to just disclose that this WebEx was created by members of Thrombosis Canada without any financial support from any outside sources. A little bit about Thrombosis Canada. We're an organization dedicated towards improving transfer of knowledge from evidence into practice, and we dedicate ourselves also to informing patients and families about adult thrombosis, pediatric thrombosis, blood thinning therapy. And if you have a moment, please check our website and click on the patient and family section, and you may find a lot of helpful resources. These include information sheets, videos, and other material to help you navigate this landscape. So let's begin by saying the question, what is thrombosis? Well, first of all, thrombosis is another term for a blood clot. And we can start by expressing the sentiment that this is a very common condition that affects men and women. And here you see a couple of these individuals. For those of you of an older vintage, you'll recognize on the left-hand side, Jimmy Stewart, and among the more younger crowd, the athletes, Chris Bosh, Serena Williams, and of course, Hillary Clinton, all of whom have had blood clotting thinning treatment. In simple terms, thrombosis is the formation of a blood clot, and it typically originates in the legs. When it does so, it is called deep vein thrombosis. And it can also migrate from the legs, where it forms, to the lungs. When it occurs in the legs, it has a number of symptoms that include what you see in front there: warmth, redness, leg pain, and tenderness, among other things. And if any of these symptoms are present, it's something that, in general, people like yourselves or others, clinicians, should think about. When the blood clot migrates and goes into the lungs, it's referred to as a pulmonary embolism. And here the symptoms are quite different, include shortness of breath, chest pain, and rapid heart rate. Now, Thrombosis Canada developed a way to help people remember these symptoms, and this is part of what we call our Clots campaign. So the acronym CLOTS refers to many of the important symptoms of blood clots, both in the leg and in the lungs. The C for chest pain, L for lightheadedness or dizziness, the O for out of breath, the T for leg tenderness, and the S for leg swelling. So if you or a family member has experienced any of these symptoms, this means that you really need to see your doctor or seek medical attention. And we're going to talk a little bit more about that later and how to do that in this COVID-19 era. So a little bit about COVID-19. Of course, we've heard much about it, and in many cases, very little else in the past 3 to 4 months. And we know, of course, that it is caused by the coronavirus 2 or SARS-CoV-2, and it is affecting at least over 100,000 people in Canada and over 8.5 million people worldwide. This is something that will likely continue for the foreseeable future. The good news is that we appear to be on a downslope in terms of both the number of cases and happily the number of deaths here in Canada. We also know that it is a highly communicable disease. and it has a typical period of incubation, which means that it can linger in your body without causing symptoms for up to about 5 days on average, but anywhere between 2 to 14 days. And that mild infection can cause symptoms that lead to recovery within about a week, whereas a severe infection, the recovery can take much longer, up to 3 to 6 weeks. You've also heard a lot recently about ways to prevent transmission of COVID-19. And this is the most recent evidence, in fact, published just about a week ago, that describes the effect of the various methods we are implementing in our society to prevent transmission of COVID-19. In this study, found that at least 1 meter or more confers an 82% reduction in transmission, and every meter that you add decreases the likelihood of transmission by twofold. So in Canada, we have the 2 meter rule. In other countries, they've adopted a 1.5 or 1 meter rule. We also know that masks have a benefit to prevent transmission, whether it is the medical or otherwise known as N95 masks, or the disposable masks that can be obtained by purchase or can be made. And finally, eye coverings as well seem to reduce the risk, and these are in the form of the plastic shield. So all of this is telling us that one or more of these measures will help reduce transmission, especially when we are in situations or environments where transmission is likely or may cause exposure to vulnerable individuals. This is a little bit about the medical aspects of COVID-19. We know that the way to detect it is through typically a nasopharyngeal swab, or a swab that goes deep into the nasal cavity, and that if the test is positive, that means that you probably have been exposed to COVID-19, whereas if the test is negative, which refers to the sensitivity, it usually means that you don't have it, but it can mean that you can still harbor the infection, and that's why sometimes we want to repeat this test a second time. Some of the symptoms you're probably familiar with. There's a lot of overlap with symptoms occurring with influenza, and in fact, in patients who have the infection causing respiratory illness, referred to as COVID-19, they can have a pneumonia very similar to that of influenza. Now, treatment has been a focus of intense research over the last 3 months. And in fact, I've been doing this for almost 30 years, and I can't remember a time when so much effort has been put in by so many scientists worldwide in such a short period of time. So I can assure you that maximum efforts are being made to optimize treatment for patients who have this disease. And right now, we know that oxygen therapy and in some cases antibiotics may help. And recent evidence has shown that corticosteroids, referred to as dexamethasone, may help those who are critically ill. And a number of other treatments, as you see there, are also being investigated. Now, at the very bottom, you'll also see that heparin, which is a blood thinner, is also being investigated because, as we'll talk about, blood clots can occur commonly in people with COVID-19. And I think this is an area of extreme interest, but also not only clinicians, but also for patients and families. So I'm going to go and now shift gears to talk a little bit about COVID-19 and thrombosis. And we're going to present some typical scenarios that may occur. And I'm going to invite our panel, Dr. Young and Dr. Tseng, to join me in addressing some of these questions. So the first one is, what is my risk for developing a blood clot or a thrombosis if I have COVID-19 symptoms that are very mild and I am staying at home looking after myself and ensuring that that transmission is not happening outside of my own home. And maybe I can ask Stephanie, what do you think we should tell people about this situation here, which is quite common?
Thanks, Jim. So, although having an infection with COVID-19 may increase a person's risk of developing a blood clot, this is mainly in patients who are hospitalized with COVID-19. So the risk for patients who are at home and have mild or moderate symptoms is likely low and not really that much different than if a patient had another viral illness such as a flu and was at home.
So I think that's a reassuring message for many people with suspected or confirmed COVID-19 who have mild to moderate symptoms, that your risk for developing blood clots, you probably have heard about this in the news, is relatively low. Another related question is that if I have COVID-19 and have mild to moderate symptoms, and again, I'm at home, should I be receiving a blood thinner such as heparin injections or even something like over-the-counter like aspirin? What do you think about this question, Stephanie?
So, as we mentioned, if you have mild, moderate symptoms with COVID-19 and but you're able to stay at home, your risk of getting a blood clot is low. So therefore, you don't need to receive a blood thinner such as the heparin type injections or aspirin. And this is as well because we know that these medications are also associated with the risk of bleeding, and in particular in older patients. So it's certainly advisable to discuss this with your physician if you're concerned about this. But as I said, most patients who are at home wouldn't need these medications.
And I would emphasize, as Dr. Young mentioned, that because COVID-19 tends to occur more in older than in younger people, even something as benign sounding as an aspirin can in those individuals promote bleeding. So we have to be careful about administering medications like aspirin even, or heparin of course, unless we have a good justification. And in people with COVID-19 must not support justifying use of these medications. We're going to switch gears now and talk about a person who may have had a previous blood clot or thrombosis. It could have been a deep vein thrombosis or a leg clot. It could have been a pulmonary embolism or a lung clot. And typically for these patients, the duration of treatment is usually about 3 months to 6 months. In some cases, it's longer. But let's talk about a person who has had a previous episode of such a blood clot, but is no longer receiving anticoagulant or blood thinning therapy. And let's suppose that individual becomes infected with the coronavirus. Should they be resuming their blood thinner? Are they at risk for getting a second blood clot? And for this, I'm going to switch to Dr. Tseng. Eric, what do you think about this very important question that we get asked a lot about?
Thanks, Jim. This question definitely has come up in our thrombosis clinic from several of our patients with good reason. The message is very similar to the previous two questions in the sense that we would think of the risk of thrombosis in patients with mild infection who are not hospitalized to be low, even if they've previously had a deep vein thrombosis or pulmonary embolism. And so we would not routinely recommend that the blood thinning therapy be restarted. Keeping in mind that patients who have previously had thrombosis may have other risk factors for thrombosis, but in general, we would not, COVID-19 infection in and of itself would not be a reason to resume in the presence of a mild infection. Now, if the patient or a family member is admitted to hospital, this is something that will come up later on, but it seems to be the patients with more severe infection and requiring hospitalization who tend to be at higher risk of thrombosis. And so the discussion about resuming blood thinning therapy is different in that situation. There are other things that you can do if you are at home with a mild infection to reduce your risk of thrombosis. These would be the things that you will have learned about previously. Things like not staying in bed, walking 3 or 4 times a day, and certainly if you do have symptoms of DVT or PE again, which Dr. Doukets had mentioned in the preamble to this presentation, then certainly don't ignore those and seek medical attention if they occur.
Absolutely, Eric. I think just simple things that, as you've outlined, can go really a long way to mitigate or prevent or reduce the risk of blood clotting. And we don't really need to resort to using treatments such as heparin or aspirin even that come with certain harms. Now, we talked about risk factors for blood clots, and there are quite a lot of them. There are some people, and there's about 1% in their blood that might predispose them toward blood clotting. This is sometimes referred to as an abnormal mutation, the factor V Leiden mutation, or the prothrombin gene mutation. And many of these individuals, although they harbor this slight abnormality of their blood, have otherwise been well and not had a blood clot occur. Now, in these individuals who may be at slightly increased risk of developing a blood clot, and once again, if they become infected with COVID-19, should they be started on a blood thinner or aspirin even to protect them against developing a first blood clot? And once again, Eric, you probably see a lot of these patients in your hematology practice. What do you think? What would you advise people about this?
So the group of people that we're talking about in this question are people who have previously been tested and found to have what's called a mutation in the factor V Leiden or prothrombin gene mutations. These are relatively common mutations that are found in the general population. Many people have been screened for this previously, despite not having a personal history of having had a blood clot previously. And so the question comes up, if you do have one of these genetic mutations, but you've never had a blood clot, should you be on a blood thinner because you might be at slightly higher risk? I think the key here is, again, just like the previous questions, the risk of thrombosis in someone who has mild infection, even with one of these abnormalities, remains low and wouldn't be high enough to justify starting a blood thinner or aspirin. Again, thinking about the potential for harm from a medication that may not have much benefit. Keep in mind, there are other clotting abnormalities that may carry a higher risk of thrombosis than the factor V Leiden or prothrombin gene mutation. In those specific situations, you should speak directly with your hematologist or thrombosis specialist for more advice on that specific scenario. But in general, we would, again, not routinely recommend starting preventative blood thinners or aspirin for people who have are at home with mild infection.
Thank you, Eric. That's very clear and nicely put advice. We're going to shift now from the home environment where COVID-19 may exist to a retirement home environment. And I wanted to sort of ask Stephanie about this question that also we get a lot, where a person may have a family member who is living in a retirement home where another resident is found to be affected with COVID-19. And that individual's family member who is otherwise well, in other words, does not have any symptoms of COVID-19, should they, in that type of retirement home environment, should they be receiving a blood thinner or aspirin as protection against thrombosis? Stephanie, what do you think we should do in this situation?
So in this case, we think about a retirement home as being somewhere where people would be living independently and would be otherwise well. So we're not referring to a nursing home, which we'll talk about it in a bit. So these are otherwise people who are well. So there's no indication, particularly if they don't have COVID-19, that they should need to have a blood thinner or aspirin. And as we've talked about as well, is that these medications also carry some risk of bleeding. So it's important to, ensure that they're not used inappropriately. So for these type of people living in a retirement home, living independently, they would not need these medications.
Okay, I'm just going to pause for a moment. There are a couple of questions from our audience. And the first one was about a person who has been on a blood thinner and has had 2 blood clots, and presumably they are on long-term blood thinner. And is there something special that they should do if they get COVID-19? And really the answer is no. Of course, you continue your blood thinner to prevent further blood clots, but there is no need to do anything more than that. There are a couple of other questions coming in, and we'll try to sprinkle some of these during the presentation, but I will leave most of them to the end, and please try to bring them in, and we'll try to get to as many as we can. Now, the next scenario relates to an individual who isn't in a retirement home, but is in more a long-term care facility, like a nursing home. And once again, if in this situation, if there is a member who is living in a nursing home and another resident is affected with COVID-19. Now, a nursing home environment, as many of you know, is quite different usually from that of a retirement home. Here, individuals are typically sicker. They need a fair bit of care, additional care, whether it's nursing or otherwise. And the same question could be posed that, well, if a family member of mine is in a nursing home and another resident has become affected with COVID-19, should they, my family member, be given a blood thinner to protect or prevent thrombosis? And I think here the situation is quite a bit different than, of course, being at home or being in a retirement home. And here there may be a case made that because there is a propensity for infection to spread, then by all means, why not provide a blood thinner just in case? Now, I say that with some caution because, as we've talked about, blood thinners come with some risks, so we have to administer them judiciously. So I wouldn't say that everybody in the nursing home should be receiving a blood thinner if one individual becomes affected. But this is something that should probably be brought up with the doctor or nurse in charge of your family member's care to see if a blood thinner is warranted. So a very different situation than being at home or being in a retirement home. All right, we're going to go switch gears a little bit further and move from the nursing home and retirement home, the community involvement, to the hospital environment. And happily, we're seeing fewer and fewer people with COVID-19 in hospital, and this is across Canada, and certainly that's the case in Ontario where I am. And Stephanie, I'm going to put this question to you about if a person has a family member who is hospitalized with COVID-19 infection and typically they are unwell, is that individual at increased risk for developing blood clots? Is this a significant risk? And should they be receiving blood thinners to prevent such blood clots from occurring? What do you think, Stephanie?
Thanks, Jim. So yes, we're moving now to the next level of patients. So these are patients who are now hospitalized. So patients with COVID-19 infections who are hospitalized tend to be sicker and tend to need things like oxygen therapy and other supportive therapy. So here we'll refer to patients who are in the hospital but not in the intensive care unit. We will talk about that as well. So patients who are hospitalized, we know that the risk for blood clots is higher as the COVID-19 infection appears to cause changes in the blood that can lead to blood clot formation. And as we've mentioned, this is certainly an area of intense research and investigation. So for these reasons, it's advisable that all hospitalized patients with COVID-19 infection will get blood thinners of what we call the heparin type. So these are injections that are given just under the skin, usually once or twice a day to prevent blood clots. So these are in patients who haven't yet developed and we know we're at higher risk. So the healthcare team looking after those patients will decide which blood thinner and what dose based on individual patient characteristics and according to the local hospital protocol, because most hospitals, if not all hospitals, certainly are going to have protocols to deal with this type of situation. There may be some situations where, for individual reasons, a patient may be not able to get the blood thinner medication. So in this case, we do have other alternatives that we can use, such as special leg stockings or compression devices that help increase the blood flow. And so in this case, what we are trying to do with these patients who we know are at higher risk is trying to prevent blood clots from happening because we know they are at increased risk.
And I just got a question from an audience member asking if an individual is already on a blood thinner and is hospitalized, what should happen then? And typically we would continue the blood thinner. Sometimes if they are on a pill form, whether it's warfarin or one of the newer blood thinners, called a DOAC, then we may switch the pill form to an injectable form because it makes it easier for the healthcare providers to do their thing in the hospital and for example, doing procedures or adjusting the dose. But if you are already receiving a blood thinner, that should be continued, generally speaking, while they are in the hospital. So Dr. Young mentioned that in a patient who is in a hospital but not in a critically ill setting, yes, blood thinners are warranted. Now, what if that person, Stephanie, goes home and they again were not in an ICU? Should they be continuing the blood thinners after they leave the hospital? And if so, how long do you think that should be for?
So for the most part, patients with COVID-19 that were hospitalized and didn't require ICU care don't routinely go home on blood thinning injections. But again, this is certainly an area of research and investigation to try and learn more information about this. However, some patients may go home and may not be fully recovered and therefore may be at continued risk for developing a blood clot. So in this case, continuation of the blood thinning treatment for up to several weeks may be appropriate after leaving the hospital. And this decision about whether or not to continue the blood thinning injections once a patient is discharged is going to be made by the healthcare team based on the individual patient characteristics. So for most patients, they will likely not require it, but there are some patients that may require it for several weeks after.
Thank you. Now, the last situation we'll deal with for hospitalized patients with COVID-19 are those who are in an intensive care unit setting. And happily, this only represents less than 5% of all patients with COVID-19 who have moderate to severe symptoms. So now, if that person was in a critically ill environment, Stephanie, and again, they're recovered and they're going home, what is the role of blood thinners in this situation?
So, as you mentioned, this is only a small minority of patients that are in this situation that do require care in the ICU. And these are the patients that are considered to be at very high risk of developing blood clots. And so they are the patients that will get blood thinning treatment to prevent this while they're being treated. And those patients, when they recover enough to leave the hospital, their risk for blood clots may continue to be high. And a blood thinner, again, would be or may be of benefit even when they've gone home. So as with patients who were hospitalized but didn't require care in the ICU, the blood thinners may be considered for up to several weeks after the patient has been discharged. And again, the team looking after that patient will decide what the appropriate blood thinning medication as well as the dose would be for that patient.
Thank you, Stephanie. So we're going to move outside of a hospitalized environment, and you've probably heard through the news about this so-called increased number of young children who have had these so-called dusky colored toes, and whether this is an indicator of COVID-19, and really what does it all mean? Well, I can first of all tell you that this is an occurrence that was actually observed in New York State and is very, very rare. Is there a relationship with COVID-19? It's not certain. Could this be some type of inflammatory process that affects the blood vessels and leads to discoloration? Possibly. I think the message here is that, first, this is a very rare situation. Secondly, if it occurs, of course, it warrants medical attention. And thirdly, it is not necessarily related to COVID-19. We're going to shift again to another population that's very important, and this is women who are pregnant. And this is a situation I'm going to ask Dr. Tseng. Eric, what about pregnant women who are otherwise well and may have COVID-19 in a mild form? Should they be receiving blood thinners during their pregnancy? What about how to deal with things after they deliver their baby? What do you think?
I think this is an important question, especially the longer we have to deal with COVID clinically. The main message here is that if you are pregnant and you do have a mild COVID infection, your risk of thrombosis remains low. And again, in most situations, we would not routinely recommend that you receive blood thinning medication either before your delivery or after delivery. The caveat to that is sometimes during the actual delivery period when patients are admitted to hospital, there may be situations around the time of delivery or just during the time of hospitalization when your medical team may recommend that you receive low doses of preventative blood thinners. But again, this is a case-by-case decision and typically only applies to the period in which you are in the hospital. The other caveat to this is that if you are pregnant but you have previously had a blood clot and you have COVID-19 infection, you should certainly discuss with your doctor about whether you should be receiving blood thinners either before or more importantly, even after your delivery, because we know that that you would be at increased risk of having another blood clot, having had one previously. The challenge with giving blood thinners, obviously, before or after delivery is that the injections that we typically use to provide blood thinning medication during pregnancy pose challenges, and again, we would not routinely recommend their use in pregnancy, even in mild COVID infection.
Thank you, Eric. Now, we've been talking a lot about COVID-19, the association of blood clots, or who are on blood thinning therapy. Are they at higher risk of developing COVID-19 infection? And I may ask someone to just move the slide along if possible. Thank you. What do you think, Eric?
So the question is whether having had a blood clot previously puts you at increased risk of either contracting COVID-19 or developing a more severe COVID-19 infection. And the answer is no. At the moment, we have no evidence or sense that having had a blood clot increases your risk of having a more severe infection. So I want to provide reassurance about that.
Okay, well, thank you. Expose you to developing COVID-19. Now, another question that has come up a lot, and it also has been in the news, is that if someone has COVID-19 infection, are they at risk of developing other forms of blood clots that can cause a heart attack or a stroke? And the short answer is that we don't think so, to the degree that COVID-19 may cause blood clots in the veins, deep vein thrombosis, or pulmonary embolism. But as we'll discuss a little bit later, if a person has symptoms or is at risk of developing a heart attack or a stroke because maybe they have high blood pressure or diabetes, they should certainly seek medical attention, irrespective of whether they have also COVID-19, because as we will talk about later, we don't want people with these serious conditions avoiding seeking medical attention. All right, we're going to switch now and talk a little bit about the effects that the pandemic and the associated social distancing has had on managing people who have, and the slides are a little bit stuck here, but I'm going to describe a situation of a patient who is receiving warfarin to prevent blood clotting because of an irregular heartbeat. This is often referred to as atrial fibrillation. And that typically with this, as those people who are taking this medication know they need to have
Jim, I think you're still muted.
My apologies, everyone. We've had our technical glitch for the webinar. This is a question I'm going to ask Stephanie about how patients who are receiving warfarin can manage in this era of social distancing. Stephanie, what do you think?
Thanks, Jim. So this is certainly questions that we started receiving in our thrombosis service right from the get-go when the pandemic started and things started to close down and be more restricted. So the first question is with regard to blood tests. For some patients, this can be the case. So for patients whose INRs have been consistently within or close to the therapeutic range for several months, the frequency of INR testing can be spread out to every 8 weeks, and in some patients, even out to every 12 weeks. So if this is done, it's important, though, to make sure that your healthcare provider who's managing your warfarin is aware of any changes in your health or medications that may prompt the need for more frequent testing. And I will add here as well that hospitals have processes in place to ensure that patients who come to the facilities are protected and kept safe from the COVID-19 infection. So I'd certainly encourage people to continue to go to their healthcare facilities to get their INR blood tests. So the next question is there another blood thinner that can be used instead of warfarin that doesn't need blood testing? And yes, for many but not all patients, there are other blood thinners called the direct oral anticoagulants, or DOACs, that can be taken instead of warfarin and don't require the same regular blood testing as is needed with warfarin. And these DOACs may be as safe or safer than warfarin, but are more expensive than warfarin. So certainly, if this is the case for any of you, I'd certainly check with your doctor to see if you're eligible, because there are some people who need to continue warfarin if you're eligible to receive this type of blood thinner. So the last question is there a way I can check your blood thinner medication effect with a device at home? And yes, for patients who are taking warfarin, there is a handheld device that uses a blood sample, a finger stick, to measure the INR level, similarly to patients who test their blood sugar with a blood glucose meter. So for patients with diabetes. So it's similar to that. However, if patients are considering using a device such as this, they do need some education about how to appropriately do the test, how to appropriately maintain the machine, and as well how to use that information that they would get from the machine to on their own or in conjunction with their healthcare provider. The other challenge certainly with these devices is that they do cost several $100s for the device itself, and the strips cost between $8 and $10 each. And the cost is not covered by the provincial or many of the private healthcare plans in Canada. But certainly if it's something that you're interested in, I'd suggest you discuss that with your healthcare provider that's managing your warfarin.
Thank you, Stephanie. And we can go to the next slide. And Eric, what about a person who has had a blood clot in their leg some months ago before the pandemic, and they're receiving their blood thinners? Do they need to go back to a medical facility to get additional x-rays to see if the blood clot is still there? This is something that happens and we're asked about very often. What do you think for this one, Eric?
So the short answer is no. In most cases, repeating an x-ray or ultrasound of the leg is not necessary, as it doesn't affect treatment decisions, and in the case of COVID-19 may make social distancing more challenging, unfortunately. And so in general, we would not recommend that repeat imaging testing would be necessary unless it's felt to be needed by your healthcare provider. So if one of your doctors has asked you to have an ultrasound done as a follow-up test, then this is something that you should discuss with that doctor directly, weighing the benefits and risks. The other thing to keep in mind about a test like an ultrasound or an x-ray, for example, is that these tests can often be done in imaging laboratories that are not in the hospital setting. So many of my patients have had their ultrasounds done recently outside hospital. in community imaging laboratories where the numbers of patients are lower and it's perhaps easier to keep social distancing. So I think this is something that should be discussed with your healthcare provider, but in general, it's not routinely recommended that all patients should have follow-up imaging, as it won't change their treatment in general.
Thank you, Eric. And a related question about visiting a healthcare facility, if we go to the next slide, is what if a person has had a previous blood clot in the lungs and they are no longer taking their blood thinner, but now they've developed chest pain or some breathing difficulty, and they might be a little bit reticent to visit a healthcare facility. What would you advise them to do, Eric?
This is a really important point because chest pain and difficulty breathing are very serious symptoms, and anyone who's had a pulmonary embolism or heart attack will tell you that. The challenge with these symptoms is that you really don't know what's happening at this point, whether it's an issue with the lungs or the heart or pneumonia or something else. So in these situations, if you're having these symptoms, I would urge you to seek medical attention promptly, to establish a diagnosis, and also to ensure that you get the treatment that you need. There have been, as Jim had mentioned before, there have been increasing reports of people avoiding the emergency room, knowing that something was happening, and often we've been seeing more and more the consequences of delayed medical attention. And I think not just for yourselves, but if you have family members who are asking you this question and seeking your counsel, this is a really important message from the seminar tonight.
And I would just emphasize Dr. Tseng's point by mentioning that, you know, the emergency departments have been totally redesigned to accommodate not only people who with suspected or confirmed COVID-19, but also the vast majority of other people who have other conditions so that they can be managed safely in that environment. So Eric, the last question would be that if we go to the next slide, what about that person who has had a blood clot in their legs and now they've got some more pain or swelling, they're not on the blood thinners anymore? Do they have to go to the emergency department? Is there another option for them to deal with this?
I think this is an important issue because often when you've had a blood clot previously, and you have recurrent leg swelling there, sometimes it could be a new blood clot. Sometimes it may be simply swelling and edema related to the previous blood clot. So I think if you're not sure and you're having very severe swelling and redness and pain, yes, you could visit the emergency room if you're having severe symptoms. However, the other option, especially during daytime hours, would be to seek out your primary care provider or thrombosis doctor to see if there's other options for sorting out what's happening. So this would include a visit to the family doctor, or as I mentioned previously, having imaging done at an outside facility outside the hospital where an ultrasound potentially could be performed without having to go into the hospital necessarily. And again, I should stress, as Jim had mentioned, that the hospital really has made great efforts in the past 3 or 4 months to ensure social distancing and also make sure that people are screened appropriately when they enter the emergency room. So if you need to go, then rest be assured that that's something that you should do. But there are options in this specific scenario for establishing a diagnosis outside hospital potentially.
Thank you very much, Eric, and thank you very much, Stephanie. So we've reached the end of the sort of structured part of this WebEx, and now we have the opportunity to answer some of your questions that have been coming in. And I'll start maybe with you, Eric. There was one question from an audience member who does a lot of traveling, and they developed COVID-19 sometime in March. And around the same time, after their travel, they also developed a blood clot, not in the leg, but in the arm. And they're wondering, you know, could this blood clot in the arm been related to COVID-19. I think it's an interesting situation. What do you think?
It's a great question, and certainly I can understand the challenge here with an upper extremity clot can be quite distressing and cause quite significant symptoms as well. The truth is, it's really impossible to know kind of without knowing more information, why the clot happened in the upper extremity there. But as we mentioned earlier in the presentation, the reports of thrombosis in COVID-19 infection have been in patients primarily with severe infections, so patients who have been hospitalized. Furthermore, the vast majority of reports of thrombosis in COVID-19 have been in hospitalized patients, predominantly with deep vein thrombosis or pulmonary embolism. So, not knowing all the information, it's hard to say with certainty, but I would say that I would be surprised if COVID-19 played a major role in why this blood clot happened, particularly if there was mild infection.
Thank you, Eric. Stephanie, here's a question for you from an audience member who wants to know what happens to people who are already on blood thinners and they go into the hospital with COVID-19. What should happen to those blood thinners? Should they continue? Should they be stopped? Should they be changed? What do you think about that situation, Stephanie?
Very good question, and I think it would depend on the situation, on why a patient has been prescribed the blood thinner in the first place. Is it for something like atrial fibrillation, or is it something like a recent new blood clot or blood clot in the past? So it's going to depend as well on how sick the patient is. What we've been seeing in terms of some of the recommendations is, particularly for patients who get admitted to the ICU, is that they may be converted over to a different type of anticoagulant, and in particular an injectable anticoagulant, because that allows more flexibility in managing that patient, as well as how often the patient has to be given the medication. So with patients who are less ill, that's going to be a discussion with the healthcare team. They may continue on with the oral medication or convert it over to an injectable medication. But it's certainly going to be something that needs kind of careful consideration for each individual patient in terms of, their characteristics, how sick they are with COVID, as well as why they were on the blood thinner to begin with.
Thank you, Stephanie. Another question, Eric, sort of I think pertains to the public's general increased awareness about blood clotting. And one person's asking, they have a couple of family members that have had blood clots, and they themselves have a blood condition called thalassemia minor. Should they be concerned about blood clotting, and should they be tested to see if they have any hereditary predisposition toward blood clotting? What do you think?
Thanks, Jim. So the situation would be someone who has had a few family members who have had blood clots, and the person himself or herself has never had a blood clot previously, and they're wondering about testing for a genetic predisposition, like the ones we had talked about in the third question of the webinar tonight. In general, most guidelines would recommend that screening for these sorts of inherited abnormalities in people who have not had blood clots is not routinely recommended, because it would be unlikely to change treatment and unlikely to change any clinical decisions that were made in the future. In the area of COVID, that also applies, because as we mentioned, an asymptomatic individual who has one of these genetic abnormalities, even if they develop COVID-19 infection, we would not routinely recommend anticoagulants anyway in that scenario. There may be specific scenarios when this testing may be warranted, but this is a decision that needs to take into account the patient's preference and a full understanding of the implications of the testing. And for a more nuanced discussion, that's something that should be had with a thrombosis specialist or a hematologist. But again, in my practice, we routinely do not offer this testing to family members who have had a family history of clotting.
Okay, I've got one more question. I'm going to stick with you, Eric, on this one. This involves an audience member who says that they were ill back in March for about 3 weeks. They think they may have had COVID-19, but they were never tested because of the restrictions at that time. They got better. And then about 3 weeks later, they developed chest discomfort, ended up being back in the hospital, and were found to have small blood clots. And this individual wants to know whether these blood clots originated somewhere else in their body, or whether they might have been as a result of their presumed but not confirmed COVID infection. What do you think? An interesting situation.
Yep, so just so if I understand the scenario correctly, it sounds like we have someone who had a relatively mild infection, not confirmed in terms of diagnostic testing for COVID-19, but they were at home for some period, about 3 weeks, and then developed pulmonary embolism thereafter. This is a difficult scenario because the question always arises, what was the illness, and did it predispose to the blood clot happening? And I suppose the answer to that lies in what the illness was like, how immobilized the person was at the time. Did they have any other risk factors for clotting, and what was their activity level like? So it's a difficult question to answer in a more fulsome way without having more information. And I think it really comes down to those specific questions in terms of ascribing whether the blood clot happened as an event provoked by an illness, or if there were other risk factors involved in why it happened.
Yes, well, thanks, Eric. It's often hard to sort of link these things and provide a smoking gun in a manner of speaking. So I think there are a few more questions that, because of the time, we won't be able to get to, but if we go to our next slide, we'll see that on our Thrombosis Canada website, we have some information for patients. And in fact, we have tried to address many of your questions that have come up in previous webinars and through our website. So please have a look at this material, and perhaps some of the lingering questions you may have are addressed. We'd also seek your assistance and input by providing your feedback for this WebEx. If you go to this site, just take 2 or 3 minutes literally to click on this and provide some feedback. We really value your input both with this educational activity and other educational activities through Thrombosis Canada. So with the last slide, I want to thank Dr. Eric Tseng, thank Dr. Stephanie Young for their expertise. We hope that we've addressed most, if not all, your questions, whether through this WebEx or through the information that we've provided through the Thrombosis Canada website. And thank you very much for your participation. Wish you all continued good health and wish you a pleasant evening. Good night.